conference, which is an imaging session related to heart failure. And I have the pleasure to co-chair this session with Professor Mohammed Usama, the Dean of National Heart Institute, and he's the chairman for Current Egypt 21. Wish you good luck, Professor. Also, I have Professor Amina Nasr, the General Secretary of the Egyptian Society of Cardiology and Chairman of Cardiology Department at Swiss Canal University. Professor Hana Mahfouz, the Chief Editor of the European Heart, Egyptian Heart Journal. And I'd like to congratulate Professor Hana for being now the International Advisor for the Royal College of Physicians in Egypt. Congratulations, Professor Hana. And we have online Professor Maya Hamdi Said, past chairman of the cardiology department at Shams University, one of the experts in the field of congenital heart disease in Egypt. And my dear friend, Professor Khalid Chokri, the president of the Egyptian Society of Cardiology. Professor Khalid, Professor Mai, do you hear us? Do you hear me?
Yes, loud and clear, Dr. Mai.
Welcome, Professor Mai.
Welcome and
Yes,
thank you.
Professor Khalid, would you like to say introduction, welcome message? Because, yeah.
Yes. First, I would like to congratulate you, Dr. Mandi, for organizing this. It contains very informative sessions and elegant speakers. Hope you will continue the meeting for the 3 days, for the coming 3 days in this level of sessions and level of the speakers and chairman. Thanks for inviting me for this session, and it is my pleasure to share
Thank you very much, Professor Khalid, for this kind welcome message. In this session, it's our great pleasure and honor to have with us today Professor Stephen Ahmed, the President of the European Society of Cardiology. And we would like to thank him very much and for his support and for his profound contribution to this conference and all our scientific activities organized by the Egyptian Society of Cardiology. Welcome, Professor Stephen. Now we will go to the first speaker.
Pleasure to be there, and I'm happy to be part of this. Took me a while to get my microphone unmuted, but pleasure to be here. Really enjoyed being part of this great conference. Congratulations on all the scientific activities that you put together in Egypt reliably always happens. So pleasure to be here.
Thank you, Professor. Professor Mohammed will introduce the first speaker.
Thank you, Dr. Mandi, for we will start with the first speaker, Professor Gani Bajante. Dr. Gani will speak about the development of new echo techniques in heart failure. Ready, Dr. Gani?
Okay. Hello to everybody. Dear friends, dear colleagues, thank you very much for the kind invitation. Thank you very much, Professor Marty. And I will just congratulate you for good sessions that you have now. I was talk about the value of new techniques in heart failure. Uh, I'm a professor of internal medicine and cardiology at the University of Pristina, Kosovo. And also I'm president of Kosovo Society of Cardiology. So I'll start my talk, but okay, I have no conflict of interest. And what to tell about the heart failure? Heart failure is a very old known disease that
Dr. Ali, please make the presentation full screen.
Life-threatening disease considered global health priority. And a lot of people are suffering from this clinical condition. Here are some data that show the importance of this disease. And also, in addition to
Dr. Gani,
the problem of the diagnosis and treatment of this disease, also the cost effectiveness is very high for this. But fortunately, today we have a lot of possibilities, a lot of tools to diagnose early this disease and to prevent the death of these patients and also disability and lose of job, etc. And echocardiography remain the gold standard in heart failure, despite the introducing of MRI, CT, and plasma technology. So in heart failure, still echocardiography is considered as a gold standard. And somebody called it the heart of cardiology, and I can also agree. Uh, what is the role of echocardiography? In fact, in addition to diagnosis, that we all know that this is very important tool for the diagnosis of heart failure, also it is important to predict the exercise capacity of these patients, the treatment, the effect of treatment, and also the prognosis or follow-up of the of the patients with heart failure. So we'll start first with the diagnosis. You see that in ESC guidelines, that suspected heart failure has some routes to come to a diagnosis. But most of these routes send us to the echocardiography. So the echocardiography remain the main tool, the main issue, the main investigation tools to diagnose heart failure. And also the class of recommendation always is class 1 software recommendation. But what about the way how to diagnose heart failure? It was an old era of echocardiography where we used in the past only ejection fraction to diagnose a patient that has breathlessness and to tell him or her that she or he has heart failure. But you see from the first echo that was 60 years ago, 50 years ago, but we have some clinical entities that two-dimensional echocardiography could, in fact, animal echocardiography could not realize to diagnose the proper ejection fraction, and that's why we use Simpson method in two-dimensional for two channels. And normal ventricular ejection fraction is the ratio between undiastolic and systolic volume. But recent decades has been shown that not only patients with lower ejection fraction has heart failure, patients with normal ejection fraction has clinical signs of heart failure. This improvement in diagnosis, improvement in this patient is thanks to the echocardiography, which had a rapid advancement. And some decades ago, not so early, that it was shown that half of patients diagnosed with heart failure have normal ejection fraction, have normal, but have preserved ejection fraction. But the last guidelines changed even more, and our life, our diagnosis daily practice is even more complicated because the patient that has ejection fraction between 40 and 49, a big discussion and controversy how to consider these patients, HFrEF or HFrEF patients. And now, actually, in actual guidelines, there is a middle range ejection fraction between 40 and 49. So there are a lot of old tools that are actually used in evaluation of heart failure, not only for the diagnosis, but also for the follow-up and for the stage of this heart failure. And this is traditional conventional echocardiography, which show the most important PA ratio and deceleration time of E wave, but even up now consider some old-fashioned measurement of heart failure. They are still actually very important nowadays in practice because they will orient us to knowing a patient is possibly diagnosed with heart failure. You see mitral inflow, but this mitral inflow that is showing that blood ventricular filling pressure, surrogate of filling pressure, has a lot of side, let's say, indication, indicated by the heart rate, by the effect of age, because you see that in patients, with young patients, different pattern compared to old patients, and also are dependent on the left ventricular filling pressure. So, based on this, the diastolic function in heart failure patients is, or in general population, including heart failure patients, is classified in normal, grade 1, grade 2, or pseudonormalization in grade 3, or restrictive filling pattern. It is a tall E and a small a, and the PA ratio is more than 2. And you see that in these patients, in this previous grade 2 of patients with diastolic dysfunction, usually the Valsalva maneuver was important to discriminate patients with diastolic and restrictive filling pattern or with normal pattern. So you see here that Valsalva maneuver is discriminating through diastolic dysfunction in this patient. And also physiological relaxation time, this time was very important for the evaluation of diastolic function in this patient. The pulmonary venous flow is also remain important, and systolic and diastolic velocities in a venous flow remain also important, and also the AR duration remains important in this patient. You see that pulmonary venous flow, it's also dependent, load dependent, and also is affected by age of the patient because the patterns of this systolic diastolic and atrial velocity are different in different portion of age patients. Later on came that's that we know before was color and mode flow holistic propagation. Color and mode flow holistic propagation was also important in the discriminating of pseudonormalization and normal and diastolic dysfunction in these patients. And you see that if the velocity propagation is higher than 50 centimeters per second, it is considered normal. But if that is lower, it is considered pathological. Also, color map and mode velocity propagation from a patient with depressed ejection fraction and impaired left ventricular relaxation. But all these measurements that we explained till now are in any way locally dependent because we usually don't measure the movement of the wall, of the myocardial wall, but we measure the velocity, blood velocity, and through the blood velocity we consider the systolic and diastolic function in this patient. And later on became very modern and very popular and actually is very useful. The tool of the cardiologist has named tissue Doppler glasing. Tissue Doppler glasing, in fact, is measuring the velocities of the myocardium itself. And these velocities are much less load dependent compared with conventional Doppler. And we see here that myocardial velocity E prime and atrial velocity A prime and systolic myocardial velocity is S prime that are important, for example, in a normal patient subject, young patient, that we have tall A prime and short A prime, and inverted E and A prime in patient with hypertension and left ventricular hypertrophy. So we can judge a this is a very useful tool for the diagnosis and treatment and follow-up of this patient. Again, we see that the inverted E prime, short E prime, and in TBI and in conventional water. And we'll see later that E conventional and E prime are very important marker for the impaired left ventricular function, in fact, for the increased filling pressure in the left ventricle. And you see here that pulmonary capillary range pressure in EE prime ratio has a very good relation, a very good correlation with an R of 0.86. That means that this was a very good news for the evaluation of the filling pressure without cardiac catheterization. The figure is used. And you see here that E prime ratio, if there is a normal, it is less than 8, it is normal filling pressure. If that is 8 to 15 is middle increased, mild increased level of filling pressure. And if this ratio is more than 15, so we can consider that we have a significant increase in left ventricular filling pressure in Also, this is, let's say, anti-competitive because there is an angle and not a parameter that is 100% sure about the left ventricular function. There is a nice paper published by Maurizio Tagliesi and his team. Unfortunately, we suffered died of the COVID-19 this year, our friend Tagliesi, that I really read several times, and this is what I suggest to uh, to read to everybody that are listening to us to know about the field pressure, the accuracy of E prime ratio in estimating the basic left ventricular pressure, and some words about the left atrium. Left atrium is also important. It's reservoir function and emptying function, volume function are very important in the diagnosis of heart failure, because usually when we have heart failure, especially in chronic one, that we will see the repercussion in the left atrium, in its role and function. And just to tell you that finally, last years, there are a lot of ongoing trials about the effect of left atrium of heart failure and its role of left atrium. And also pulmonary artery pressure, systemic pressure, measured by acoustic regurgitation velocity, that is old one, but is very useful and very nowadays in practice. And but which are other reasons for the heart failure? Pericardial disease, mitral stenosis, mitral regurgitation, in addition to hypertensive disease.
Dr. Rani, Professor Dr. Rani.
Left ventricular and left atrium.
You hear me?
Yes.
Because of time, thanks for your elegant talk. I have one question. You concentrated on the histology of the left ventricle and left atrial size. Dr. Jamila, you have a question? Dr. Hala is having a question. She will ask you about.
Thank you so much, Professor Rani. In fact, I would like to thank you so much for your great contribution to the Egyptian Heart Journal. You are one of the eminent reviewer in our journal, especially in the echocardiography and non-invasive field. So thank you so much. This is my first statement. Second is the role of the deformation imaging in understanding the mechanistic approach of the heart failure and a better understanding of the cardiac phenotype in heart failure patients. Now they put three classifications for heart failure: the longitudinal dysfunction, the transmural dysfunction, and septal-pharyngeal dysfunction. I do agree about this categorization of heart failure patients, especially at the level of risk stratification.
Thank you very much, Professor. It's unfortunately, due to the restricted time, I couldn't show my slides about the strain and the speckle tracking that will show this stratification that you mentioned, and I totally agree with this new guideline and new classification that you mentioned. So I agree with that.
Thank you so much, and we will move now to the.
Thank you very much. much, dear friend Gani, the elegant presentation. Thank you very much for your participation and your great contribution to the conference. See you later. Thanks again. Now I have the pleasure to introduce Professor Stefan Achenbach, President of the European Society of Cardiology, Professor of Medicine, Chairman of the Department of Cardiology, University of Erlangen, Germany, founding President of the Society of Cardiovascular Computed Tomography. Again, I'd like to thank Professor Stephen for your tremendous effort, taking time to be with us today in this conference. We cannot express how grateful we are to have you today. And in spite of the pandemic and the challenge that we have in this global pandemic, Professor Stephen is committed to support scientific activities of all national cardiac societies. And the Egyptian Society of Cardiology, one of these national societies. So welcome, Professor Stephen.
Yeah, welcome back. It's my pleasure to be here. As I said before, always happy to contribute. Also, Gani, good to see you, my friend from Kosovo, but really good to come together. It's different form now, right? In Zoom meetings, better than nothing. It's a pleasure to be here. You want me to
Nice to
start?
see you again.
Yes, good to see you also. And thank you to all the commitments that members of the European Society of the Egypt Society of Cardiology have done to help the ESC this year. Many of you are meetings, and we really, really value the high quality that you provide to the meetings. Thank you.
Thank you for being here.
Well, I guess you want me to start. So, talking about heart failure, and the question is what cardiac CT can potentially contribute to the workup of patients with heart failure. And in fact, let's take a step back and think what CT can give us. We know that with modern CT systems, image quality of the heart has tremendously improved, and dedicated CT systems are really good now to visualize the heart and the cardiac anatomy. With a modern CT system, you can typically acquire approximately 300 slices of the heart, very thin slices. Within a few seconds, the heart can be covered. The temporal resolution is about 100 milliseconds, order of magnitude about 100 milliseconds. So you can freeze the motion of the heart, and you can see the cardiac structures sharply and without motion artifact. Images are synchronized to the EKG, and the resolution of the images that are acquired is very high, approximately 0.5 millimeters. So you can see the amount of detail that is supported in these images. The aortic valve, the mitral valve, you can see the papillary muscles and the tendini, caudate tendini going from the papillary muscles to the mitral valve. The pericardium here, the coronary artery, and the small coronary vein next to it, lipid calcification. So all of this can be seen in the image because the in-plane resolution is 0.5. And the images are also approximately 0.5 millimeters thick. And this is very, very important because these thin slices have the same resolution across the slice as we have in the slice. This is what we call isotropic resolution. And because we have these very, very thin slices, different from any other imaging modality, we can reformat the data and look at the heart in different planes, any plane that is desired, and always retain full resolution, because the slice thickness is approximately the same as the in-plane resolution. So based on this axial slice that was acquired, 300 such axial slices, we can reformat, generate different planes, and still have images because they are composed of so thin slices with very high resolution. That's the particular advantage of cardiac CT. This isotropic resolution is something that other imaging modalities like MR or echocardiography do not offer. And this is why CT can visualize cardiac morphology with an amazing amount of detail. Here we can see two cases. There's a ventricular septal defect here. You can see the amount of detail here. There's a tiny paravalvular leak next to an aortic valve prosthesis. You can see the paravalvular leak, and because we can orient the slice in any orientation that we want, and then have the full resolution, these anatomic situations can be visualized with so much clarity. That's the advantage of cardiac CT over other imaging modalities. Here you can see the amount of detail. Heart failure, cardiomyopathy, this is a case where we see some non-compaction. You can see the degree of detail, the ability to measure, and to generate any platelets possibly desired. It is also possible, even though not always done, but possible, to acquire data sets that cover the entire cardiac cycle and to show morphology in motion. We cannot see flow, we cannot measure pressure, but we can see the morphology during the cardiac cycle, and again, look at the spatial resolution, the temporal resolution, and you can see and can imagine that this allows rather detailed assessment of cardiac function if desired. Here you can see a case where clearly we have a large inferior scar of the left ventricle with severely depressed left ventricular function, also right ventricular function, as you can see here, is severely depressed. You can see the amount of resolution in these images. This is a pseudo-aneurysm of the left ventricular case that we just had last week, but it demonstrates once again the degree of accuracy with which CT can visualize anatomy with isotropic resolution and also function with very high resolution. This is what CT can do. And there are some number of advantages next to the high resolution and the ability to generate arbitrary planes. There's also the advantage that metal in cardiac CT is typically not problematic. It might be causing some local artifacts. This is an ICD lead, which contains a lot of metal, so you get some local artifacts, but overall image quality is usually still good enough to visualize cardiac morphology with a high degree of accuracy. There are also some downsides, obviously, that need to be considered of cardiac CT when we look at LV function. We have radiation. There is the need to inject contrast agent, something that neither magnetic resonance nor echocardiography routinely require. And also CT is not so good at soft tissue characterization. You can see here a thrombus, you can see the myocardium, and you can see that the density difference between these two structures is not very high. So there's no reliable separation of various tissue densities. And for soft tissue differentiation, cardiac CT is not particularly good. Calcium, excellent, but for soft tissue, CT is not so good. Look at this example here, where in the apical region there's probably a thrombus, but it might also be myocardium. You cannot see this so clearly, and this is something where CT is not particularly strong. So this is the downside of cardiac CT. And you know, CT is sometimes suggested to be used for late enhancement. This is, of course, where MR provides fantastic tissue characterization. Here you can see a practical example of a patient who had a suspected sarcoidosis of the heart, but an ICD had already been implanted. So it was attempted to do late enhancement by CT, and yes, the images were good enough to see the typical septal thinning here and late enhancement in this region. There's also some apical late enhancement, but compared to the signal and the contrast to noise that you get in MR, you can see that CT is significantly worse. There are also some published data that look at late enhancement in CT, and yes, it can be done, but see, you know, this is the sort of image quality that gets published. This is an example from our institution. Yes, late enhancement is possible by CT, but it's difficult, you know, substantially worse than the signals that we get in magnetic resonance. We also heard about LV function in echocardiography just from Bani Mangaktari, and of course, strain analysis is something that is very easily done by echocardiography and also by magnetic resonance. If there have been attempts to do the same by CT, and a number of papers have been published, but it's only a surrogate. Here you can see strain analysis by CT, but it's not the same. It's looking at the images in a slightly different way than in tagged MR images, so in true strain imaging by echocardiography. There's a sort of rather close correlation between CT and echocardiography, but CT cannot compete with the high degree of accuracy and reliability of strain analysis in echocardiography, or possible, but not something that is used clinically. This synchrony can be assessed because we have the very high resolution. We can visualize this synchronous left ventricular contraction. There has been data that wall motion on CT was associated with MACE-free survival, but then it was tried, the authors tried to use this to improve the outcome of CRT implantation, and then there was no positive effect of CT. So all the things I've shown you, late enhancement, straight analysis, this synchrony assessment, yes, this can be done by cardiac CT, but for clinical routine, this plays no role. We have better techniques for this, echocardiography, mainly and MR. But there are some areas where CT has clear advantages, and they might occasionally become important in the heart failure patient. Whenever visualization of calcium is required, CT is absolutely perfect. You can severely calcified pericarditis, and you can see that the calcium is infiltrating into the left ventricular myocardium. And as I said, if you want to visualize calcium, then CT is really the method of choice, and much better than any other imaging modality. Similarly, because CT has relatively little problems with metal, there's the occasional patient with a left ventricular assist device in whom echo imaging is challenging. Look at this patient where it was trying to look at LV function with an implanted left ventricular assist device, but the best images that could possibly be acquired was this. MR, of course, is not possible with a large implanted left ventricular assist device. And with with CT, there's no problem. Yes, you have an artifact caused by the pump itself, but you can wonderfully visualize a left ventricular function in these patients. So this is something that is sometimes used clinically to assess LV function in assist device patients. Here's another patient, and you can see how nicely you can analyze left and right ventricular function with the left ventricular assist device. We do this occasionally, and others also. This is one area where CT might be useful in patients for assessment of left ventricular function, which is usually done by echo and MR. Also, complications of assist devices. Here, for example, you can see that the inflow cannula is adjacent to the left ventricular wall and gets obstructed by the left ventricular wall in systole. So CT has a role, and this has been described in assessing complications and problems with assist devices. In generally, if we think about CT for general cardiac morphology and function in the context of heart failure, here's another example that shows how accurate CT is and how impressive the images are. This is a calcified but nicely working aortic valve bioprosthesis. So CT is highly accurate for cardiac morphology and function. It is particularly good for looking at calcium, for looking at patients who have a large amount of metal or implanted devices, but there are severe disadvantages, for example, poor tissue characterization, very, very poor ability to do leg enhancement. We can do strain, but not very well. Flow and pressures cannot be measured at all. So overall, except for occasional exceptions, there's a very limited clinical role for CT to look at left ventricular, right ventricular function and or morphology in patients with heart failure. It's a backup that can be used if other modalities fail. Now, the one advantage of CT is clearly looking at the coronary arteries. We all know that CT can provide wonderful image quality if the scans are done correctly and carefully and with good equipment. 64-slice CT should be used. Patients should have a sinus rhythm, and patients must be able to follow breath commands. The heart rate should be lowered for the scan to less than 60 beats per minute to always reliably get good image quality. There's a bit of radiation necessary, but then images of the coronary arteries are typically very high resolution, and in the general population, the sensitivity to identify coronary stenosis is about 96%, the specificity 80%, and there have been two published trials looking specifically at heart failure patients, both around 100 patients, and they showed very high accuracies to rule in/rule out coronary stenosis in heart failure patients, 90% sensitivity and 97% specificity. In this trial, 99.5% sensitivity and 98% specificity in this trial from Italy. Italians are always very optimistic and very enthusiastic about cardiac CT. But they show that if you want to use CT to rule out coronary stenosis in patients with heart failure, this can be rather enlightening. This is why there is a class 2B recommendation that it should be considered to use cardiac CT to rule out coronary artery stenosis in patients with heart failure. This is the heart failure guideline from 2016. In the ESC guideline from 2019, there's even a class 1 recommendation that you can use coronary CTA, whatever the reason is that you want to rule out coronary artery stenosis and the pretest likelihood is estimated to be relatively low. Now the guidelines even give us a class 1 recommendation to use cardiac CT. So in patients with heart failure, if you want to rule out coronary stenosis, CT is an option, especially significant coronary artery disease seems unlikely, but it requires that patients have a sinus rhythm. Patients should be able to hold their breath, follow breath-hold commands. Preferably, you should be able to lower the heart rate, so not every patient with heart failure is a candidate for cardiac CT. Last slide, summary. Cardiac CT and heart failure. Thank you for giving me the opportunity to speak about it. But in general, I would say that using CT for morphology and function in heart failure is a niche application. The occasional patient where other imaging modalities fail, CT can be highly accurate, but it is very infrequently needed. The downsides are poor tissue characterization, lack of reliable late enhancements, lack of a reliable assessment of strain. All of this is, of course, important information in heart failure these days. But it is an option to rule out coronary artery disease if patients are well suited for the cardiac CT scan, if the likelihood is low, and particularly angiography for some reason is undesirable. And with this, thank you very much for your attention. It was a pleasure to contribute. And if you have questions, of course, I'd be happy to answer.
Thank you very much, Professor Stephen, for this elegant presentation. We have one question from the attendees. He's asking about the role of CT in LVAD, that it has rolled outflow cannula for LVAD. He's asking about is it reliable to use CT to assess inflow cannula or pump thrombosis?
Yes, the inflow cannula is pretty good to visualize by cardiac CT. Inside the pump, you can't see. Usually, you can suspect pump thrombosis based on the power consumption of the pump, but you cannot see it by CT. The cannula is better, and that can usually visualize. But the pump itself, you cannot see inside.
He's asking also about which protocol to use to assess delayed enhancement by CT.
Well, there are a number of protocols and nothing is really prescribed, but usually it's good to use low kV, 80 kV, 90 kV, 100 kV, because it gives you good contrast of the iodine, and to wait about 15 minutes after injection of contrast. The amount of contrast is usually about 100 or 120 cubic centimeters of contrast. And this is usually what is best done. You should also reconstruct relatively thick slices. Don't reconstruct very thin slices because then the image to noise ratio will be disadvantaged. So thick slices, low kV, wait about 15 minutes. This is typically the protocols that those who do cardiac CT for late enhancement will use.
Any questions from the chairpersons? Professor Mai, Professor Khalid. We have also Professor Azza Fehmi, the chairman of the echocardiography working group. Dr. Mai?
May I have a question, please? Hi, thank you very much for the wonderful talk, Dr. Stephen. One question, do you do 3D printing? I mean, is this in your lab safe for LVAD to measure the cannula, how much it's going inside? Is it going to meet the wall? Does this...
Well, I think this is a very interesting idea that you're proposing, but if you would do 3D printing, you would probably have to use systole and diastole to see whether there's any obstruction. This can, I think, can be more reasonably done using just the data set and looking at the data set. We have been doing some 3D printing, not routine, but as part of research protocols, for implantation of devices. For example, left atrial appendage occluders. We have done a series of patients where 3D printing was used to find the best size for the occluder, and we could show that this is more reliable for sizing than using the 2D images. But
for PSDs as well. No?
yes, and we have not done it for VSDs, but others have. So the target procedures, the 3D printing has not been really successful. So we are carefully moving in the direction of 3D printing, but most likely 3D printing is only an intermediate step, because those who are very clever with computers can simulate everything just using the computed data sets directly and don't have to go through the step of 3D printing.
Thank you very much.
Okay, thank you very much, Professor Stephen, for your active participation and for excellent contribution to the program. Thank you.
You're welcome.
See you. So for the sake of time, we have to move to the next speaker, Professor Jamil.
I have the honor to introduce the next speaker, Professor Ahmed Tajuddin. To the next speaker. دكتور أحمد. دكتور أحمد تاج أستاذ إدارة القانون المساعد كلية الطب جامعة السويس. الحقيقة احنا يعني almost proud إن يبقى our department دكتور أحمد لك بس الوعد اللي احنا فخر الاسم بتاع presentation today.
May I ask you to keep all discussions in English, please, because we are having audience from all over the world. Thanks for your understanding. Okay, thank you very much.
I have the pleasure to introduce Associate Professor Ahmed Tajuddin, who is from Suez Canal University, and I have the honor to present him today and his presentation about biomarkers and heart failure recent updates.
Thank you very much, Professor Gamila, for introducing me for this important meeting, and I'd like to thank Professor Magda Abdelhamid for inviting me for this important meeting about heart failure. My title is about biomarkers in heart failure recent updates. Once more, thank you. And we are in Corona era, and I hope that at some point we can meet again in open fresh air in Ismailia. This is one of the most popular places in Ismailia, and now it will be a museum for Suez Canal area. According to Socrates, you don't see what you don't know, which means you don't see by your eyes what you don't know by your mind. Heart failure is a growing epidemic worldwide with increasing prevalence and incidence, with billions of dollars spent every year for treatment and prevention. The growing prevalence of heart failure is due to increasing care post-MI, aging population, and improved survival overall in risk factors of cardiovascular disease. The ugly face of heart failure, that the number is increasing worldwide, more than 25 million now. This data is at 2015. Economic burden about 110 billion per year. Mortality, 50% of heart failure patients will die within 5 years. Heart failure is number one cause of hospitalization worldwide. Heart failure is one of the most prevalent diseases with comorbidities. Pathophysiology of heart failure, as you all know, ischemia, oxidative stress, ATP depletion, with different myocyte, neurohormonal, and molecular changes leading to structural changes at the level of the chamber dilatation and functional changes in the level of ejection fraction and cardiac output dysfunction. Heart failure is associated with cardiac remodeling, which consists of necrosis, fibrosis, hypertrophy, cardiac myocyte, extracellular matrix damage, overactivation of neurohormonal And you can see here that with each component of heart failure, with each component that is for myocardial stretch, there will be some biomarkers, important biomarkers for matrix remodeling. There are other biomarkers like NNP, like interleukin 6. For myocyte injury, there is one of the soluble suppressor to tumorigenesis, factor 2, and osteopamine. For oxidative stress, there is oxidized LDLs, urinary pyurines, and others. For inflammation, there is CALB and tumor necrosis factor alpha. For new hormonal activation, norepinephrine, renin, and angiotensin 2. And for renal dysfunction, there is NAG and what's called cystathine C. So in heart failure, there is oxidative stress. So there is oxidative stress with uric acid and myeloperoxidase as biomarkers for this. There is myocardial injury, troponin, creatine kinase, and FABP, H-type, R-type. Renal injury, creatinine, cystathine C, and NGAL. Fibrosis, you find ST2 and galectin 2 as example. Inflammation, high sensitive active protein interleukin 6, chamber dilatation, natriuretic and then neuroendocrine processes like MR, adrenaline, and cocaine. From those biomarkers, there are what's called the established biomarkers like PAP and NT-proBNP, and this is for myocardial stretch. We have troponin T and troponin I for myocardial injury, and there is soluble ST2 and galectin 3 for hypertrophy and fibrosis. All other biomarkers are still not standardized biomarkers for heart failure. So the main groups of biomarkers for heart failure: myocardial insult group, neurohormonal activation group, and remodeling group. What is the criteria of novel heart failure biomarker? It should undergo thorough evaluation to assess those markers in a wide range of randomized clinical trials, can be easily and quickly and accurately measured, demonstrate important components of heart failure pathophysiology, and provide important clinical information for heart failure pathophysiology. According to the different guidelines, American College of Cardiology, European Society of Cardiology, and Heart Failure Society of South America, for example, American College of Cardiology adopted natriuretic decline as class 1 recommendation to support diagnosis, to exclude heart failure for prognosis and for admission levels of acute decompensated heart failure. While European Society of Cardiology adopted natriuretic decline as class 2A in initial assessment of newly diagnosed patients with heart failure, HFSA recommended natriuretic decline in diagnosis but not as routine screening in asymptomatic patients. American College of Cardiology class 1 recommendation for myocardial injury for additive risk stratification, like troponin T and troponin I. European Society of Cardiology class 1 recommendation for diagnosis of suspected acute heart failure. Soluble ST2, which is suppression tumorigenesis 2, and galectin, approved by American College of Cardiology as class 2B as additive risk stratification in ambulatory and acute decompensated heart failure. Those important biomarkers regarding stretch biomarkers or necrosis or insult biomarkers or ST2 and the galectin biomarkers, they are all adopted as the standard one. There are many other biomarkers which we'll discuss as the recent updates for possible use in the clinical. So let's start with the old one, natriuretic peptides. There are so many trials expressing how they could be used as an assessment in diagnosis and in follow-up of patients with heart failure. And those therapeutic peptides, despite some, I would say, some fallacies in assessment and some false negative, false positive results, still one of the most important biomarkers for heart failure, representing myocardial stretch in so many trials. Most of them were randomized controlled trials. One of the new or recent biomarkers, MR, which is mid-regional pro-atrial natriuretic peptides, and it reflects myocyte stretch. However, you can see that there is a small number size trials, and they found that it's independent predictor of mortality in patients with heart failure. However, limitation that in most of those trials, it didn't include high-risk patients, and in some other trials, we didn't know any idea about PEP. So this is why it's not used as routine use in heart failure. Another one is EGYHF, which is growth differentiation factor. There are some trials, as cohort and randomized trials, with a relative good number of patients, and it was associated with long-term cardiovascular outcome. However, those trials have some sort of high range of measured GDF-15 and some sort of changes in the number of when to say this is high or low. If we go for the myocardial injury, troponin is one of the standard biomarkers for myocardial injury in heart failure. There are so many trials with very large numbers. This one, the meta-analysis proved that troponin TMI are important in identification of patients with acute decompensated heart failure and prediction of mortality. Heart-type fatty acid protein is one of the recent biomarkers. Again, it's not in the guidelines yet. There are many trials with large numbers. It's very valuable as indication of latent and ongoing cardiomyocyte damage. However, small number of participants and value of testing, especially in this with chest pain, is not appropriate. If we go for the oxidative stress, we have myeloperoxidase. There is some trials, cohort trials with relatively large number. There is independent association between MBO and development of heart failure in apparently healthy elderly subjects, so it could predict future heart failure. However, there are some lack of careful characterization of other comorbid conditions. If we look at the serum uric acid, is one of the metabolites of urine, and it's related to cardiovascular disease, oxidative stress. There are so many trials with large number that the higher the serum uric acid, the worse the prognosis of heart failure and cardiovascular disease. If we look at the inflammatory markers, high sensitive C-reactive protein was tested in so many trials with large number of patients. There's direct correlation between C-reactive protein and progression of heart failure. Pro-calcitonin, there are again large number of trials reflecting that PCT levels increase significantly with increasing severity of heart failure. And if we go for the fibrosis and matrix remodeling, there is soluble ST2, soluble suppression tumorigenesis 2. It's reflecting a marker for hypertrophy and fibrosis. Relatively small number of trials is one of the clinical predictors, especially when combined with NT-proBNP in patients with heart failure. Again, is not yet standard of care biomarker. Galectin-3, again, reflecting hypertrophy and fibrosis, but small number of studies, and there is echocardiography wasn't followed up in most of the studies involving galectin-3. If we go for the next, it's neuroendocrine. We have endothelin 1. It was tested in one of the trials. Increased concentration of endothelin 1 is associated with poor prognosis, especially in presence with pulmonary hypertension. Arginine vasopressin or cobintin again was tested in many trials. Some meta-analyses revealed that elevated levels of cobintin protein highly associated with increased risk of heart failure and all-cause mortality. And if you go for renal injury biomarkers, cystatin C was tested in relatively small number of trials. High levels of cystatin C is associated with all-cause mortality and poor cardiovascular outcomes. However, elderly and predominantly male participants were used or participating in such a trial. NGAL, which is neutrophil gelatinase associated biomarker, was tested in some trials and it reflects tubular damage as indicated by increased urinary levels, but it is not one of the standard ones. In patients with heart failure and preserved ejection fraction, all these biomarkers are still valid for the same indications. This is one of the trials which used combined biomarkers like NT-proBNP with high-sensitive C-reactive protein. It was additive for prognostication of heart failure. And when most of those biomarkers tested as specificity and sensitivity, they were sensitive and specific for heart failure outcomes, except MR proadrenomyoglobulin is not sensitive or specific. Actually, I'll give just 1 minute extra if you don't mind. Those are the biomarkers of heart failure. I would go for oxidative stress, myocardial injury, renal injury, fibrosis, inflammation, chamber dilatation, and neuroendocrine. And those, the standard approved biomarkers, BNP and NT-proBNP for support the diagnosis and follow-up of patients with heart failure, and supporting the idea of that the higher the NT-proBNP, the poorer the prognosis. For myocardial injury, troponin and troponin I. For myocardial fibrosis, we have soluble SCT2 and galactine as class 2B indication. Thank you very much.
Thank you very much, Dr. Ahmed, for this presentation as usual. I'm asking about the multi-marker approach. Do you think that we can use all the marker to get integrated information?
Yeah, actually, multi-marker approach since 2015 was actually tested in many trials. One of them, I just mentioned just one, which is the heart failure trial. And the more biomarkers you use, the more valid you are using a model for prognostication. Because sometimes NT-proBNP affected by presence or absence of HF, presence or absence of comorbid condition like COPD, infection, renal impairment. So if we add TAT, high sensitive troponin, for example, it will be additive biomarker and risk factor in prognostication for patients with heart failure. And in one of the studies, they used 6 biomarkers. One of them was NT-proBNP, then soluble suppression tumorigenesis, and some other biomarkers. The more biomarkers you use, the more you can characterize patients with heart failure. However, this is cost, time, and feasibility. Is it feasible to do that for all patients or not? However, yes, multi-marker approach is adopted at the moment, and there is some sort of age and gender specific biomarkers.
Thank you very much, Dr. Ahmed.
Thanks, Helen.
This is comprehensive talk, and we move to our last
Thank you
speaker.
very much. Thank you.
In fact, I am honored to introduce one of our eminent professor in cardiology, Professor Dr. Abdullah Al at Cairo University. He's the one who created the CMR and how we prefer CMR always in cardiology and in cardiac patient. And his thought in heart failure is very important despite the fact that it's challenging. Professor Abdullah Al will talk about the heart failure and
the role of CMR.
very good, yes. The CMR, a rule for CMR in heart failure patient. Almost answer, and he will explain why yes. Professor Abdallah.
Good evening, everyone. Thank you, Dr. Hala, for your introduction. And actually, if you're watching us online, we have very eminent cardiologist, top of cardiologist here as chairperson. And I would like to thank the organizing committee, especially Professor Magda Abdelhamid, who actually asked me to talk about my favorite cardiac imaging modality for patients with heart failure. So, as you know, imaging has a central role in evaluation of patients with heart failure. And I have to say that the initial clinical assessment of patients with suspected heart failure should be with echocardiography as the first modality of choice, and will remain for the foreseeable future the echocardiography. It's widely available, versatile, has low cost. However, etiological diagnosis cannot be established in a significant number of patients with heart failure, despite significant advancement in echocardiography technique. So what is an ideal imaging modality for detection of heart failure, for inflammation, fibrosis, infiltration? You need an imaging modality with high spatial and temporal resolution. This modality should detect myocardial edema and inflammation of the heart, detect the amount of fibrosis, and even the transmural extent of this fibrosis. It's preferred to be radiation-free and should be very accurate in assessment of LV and RV function and viability. It's better to be operator independent. And in addition, we need true 3D imaging modality that you can use in any plane, to be independent of any geometric assumption for the calculation of volumes and ejection fraction, to be independent of acoustic window. You cannot just write a record that the patient has a bad acoustic window with unlimited field of view, what we say a part of one-stop shop. And if we just change the title here, the cardiac MRI has all of these advantages. CMR actually is the only imaging modality that has the ability to assess without exposure to ionizing radiation the cardiac function, the structure, what we call tissue characterization, perfusion, and viability. I'm not going to talk about the MRI physics, but actually MRI is just imaging of water. And since our body have a lot of water, and we have abundant hydrogen protons, as you see in this figure, from the processing or the rotation of the proton of the hydrogen atom, the water molecule in our bodies, we get the image. And we get actually and we get here what is called T1 and T2 characteristics for every single tissue that allow us for doing a tissue characterization. So myxoid tissue will be different from fat, from necrotic tissue, according to the T1 and T2 value and the characteristics of the tissue when we inject gadolinium. And this is an example of how different the parameters of T1 of T2 in different tissues in the body. And this is called the tissue. This is the tissue characterization. And this is give us one of the strengths of the cardiac MRI, what is called the component or the pulse sequences. And as you see here, we have multiple pulse sequences and modifier that we can use to get different images. If you look at this picture here, so it's the same cut of the short axis with different pulse sequences, and you can appreciate that different pulse sequences will give you different information of the heart. For example, for iron deposition or for patients with iron overload cardiomyopathy, this is an example of the procedure of cardiac MRI, which takes like 1 minute only, or maybe less, just to detect the T2 star. It's a value that you can appreciate, you can measure it at the septum, and you can, if it's above 20 milliseconds, that will consider normal. So what's the role of CMR in detection of fibrosis and infiltration of patients with CMR? So if we talk about the heart failure, we have ischemic heart disease, we have cardiomyopathy with all of these categories, hypertrophic, dilated, ERBC, restricted, unclassified, and also we cannot ignore myocarditis. Delay hyperenhancement actually is one of the hot topic, and it's very, very useful modality in cardiac MRI. And actually, without having the delay hyperenhancement technique in cardiac MRI, it will lose around maybe 50% of its power. And as you see in this famous slide, that CMR can detect even small areas of fibrosis. We just inject the gadolinium, wait for 7 to 10 minutes, and then we look for the scar. And as you see here, this is a big scar in the infralateral wall. And of course, the mechanism that the gadolinium will be trapped inside the myocardial tissue and will shorten the T1 and increase the signal. But again, here you can differentiate between what is called subendocardial scar and transmural scar. So transmural scar will just get the whole myocardium, and you know that the chance of the patient after revascularization will be much less if the patient has a subendocardial scar. Also, we can differentiate between acute versus all pathology using what is called T2 weighted images. As you see here, this is the T2 weighted image of myocardial infarction, and here's the area of inflammation. However, in chronic myocardial infarction, you don't see this T2 weighted images. This is an example of a 52-year-old man with history of chronic inferior MI, and he was referred for assessment of myocardial viability. And as you appreciate here in the short axis view, there's a transmural scar in the inferior and infralateral wall. And even if you look inside this scar, you will find this black tissues or dark tissues, and that is what is called microvascular obstruction. So you know that this patient will have difficulties in revascularization if you insist just ignore the viability and do the PCI, you will fix the problem of microvascular obstruction. So, myocardial viability by CMR will solve the clinical problem of viability. Patients who have viable myocardium may benefit from revascularization. Those with non-viable myocardium preferably will not benefit from revascularization. And this famous study showed the relationship between transmural extent of delay hyperenhancement before CABG and the likelihood of increased contractility. And as you see here, the more viable myocardium, the better the chance to increase contractility after the surgery. Not even just detect the fibrosis and the extent, the pattern itself will help us just to know or differentiate between ischemic versus non-ischemic cardiomyopathy. In ischemic cardiomyopathy, as you see here on the left, you have either a subendocardial infarction or transmural. You will never have an ischemia with subepicardial or mid-myocardial scar or fibrosis. And even with non-ischemic etiology of heart failure, you can give us a clue without getting a biopsy or from something like that, just to know the etiology. So if you have a mid-wall sign, that will tell you that this patient has a dilated cardiomyopathy, myocarditis. If you have it at the insertion point of the RV into the septum, this is the typical pattern of hypertrophic cardiomyopathy. If you have it at the basal infralateral, that will go with sarcoidosis or Fabry disease. As you see here, the amount of fibrosis, you can see different pattern. One here on the left is for myocarditis. It's patchy, it's small focal patchy areas of fibrosis. In the middle, you see the hypertrophic cardiomyopathy, and you can appreciate the amount of fibrosis in the septum, which actually increase the risk of patients for sudden cardiac death. And in dilated cardiomyopathy, as we said before, this is a mid-wall sign that will tell you that this patient actually reached a stage of maybe an end stage of dilated cardiomyopathy. Of course, cardiac MRI is a gold standard for assessment of function. As you see here, it has a high resolution. This is the four-chamber. This is a two-chamber view. This patient has, if you look at the inferior wall, there is a large pseudoaneurysm. And of course, we use the short axis to measure the LV and RV volumes and ejection fraction. Because of its high spatial resolution, you can easily just diagnose in some cases with LV non-compaction, where the non-compacted myocardium to the compacted myocardium ratio is more than 2.3. The most three important sequence that we use in cardiac MRI for detection of myocardial edema is the T2-weighted images, detection of myocardial fibrosis by delayed hyperenhancement, and assessment of cardiac function by the steady-state reprecision. For example, this is the case of hypertrophic cardiomyopathy, and you can appreciate the septum, which has many high burden actually of fibrosis at the mid-septum, here also at the anterior wall. And this will actually open the discussion whether these patients with heavy burden of fibrosis will need an ICD or not. Also, this is another example of a 45-year-old man who was previously healthy. He has a progressive shortness of breath 5 months ago, and his echo showed apical hookah, and the patient was managed by beta blocker. However, after 5 months of treatment, there was no improvement, and actually, clinically, the situation gets worse. This is a four-chamber. And actually, if you look here, it looks like really apical hookah, but when we do other sequences, as I told you, these are the weapons of cardiac MRI. If you look at the perfusion here, on the left, I mean, this one on the left, you can see that this is natural, that is not a myocardium. It's either looks different from the signal, look different from myocardium, and even in the and when we inject the gadolinium, we see the difference. This is not myocardium, definitely. This is a thrombus, and this lining is a diffuse fibrosis, which we see usually in endomyocardial fibrosis. So here the management was changed just to give us to give the patient more corticosteroids and different management. We stopped the beta blockers, and he gets better. This is example of 49-year-old man with intermittent chest pain, lightheadedness, and palpitation. And as you see in the RV, there's areas of dyskinesia. This patient has a ventricular tachycardia, and he has actually fibrosis at the RV wall. But this is not the most important thing according to the revised task force criteria, which needs one of these echinacea or dyskinesia or synchronous RV contraction with dilated RV or RV ejection fraction less than 40, which this patient has received. This is another example of 25-year-old male who has obstructive cardiomyopathy shown by echo, and the CMR was requested to identify the etiology. This is a four-chamber view in steady-state precision, and as you see, there's non-dilated ventricles, large areas, reduced longitudinal shortening of the LV. And most importantly, the delay hyperenhancement show diffuse subendocardial enhancement. So all myocardial signals have subendocardial. So this is not ischemia. We don't see this in ischemia. All the territories are included. No, this is actually pathognomonic of cardiac amyloidosis. So when we see this picture, we know that we're dealing with cardiac amyloidosis. If you look here at the right, this is diffuse subendocardial LV fibrosis here. As you see, the mouse is not working, I'm sorry. And we use the tagging technique. This is another modality that we use in CMR, just to show the deformation of the myocardium and can measure the diastolic dysfunction. Finally, I'm going to talk about the role of CMR in myocarditis and for all pancarditis, pericarditis, myocarditis, endocarditis. Just give an example of each of one. This is an example of patients with Dressler syndrome. He has a myocardial infarction followed by inflamed pericardium. As if you look here at the pericardium has an increased signal. You see these two lines, two white lines. This is inflamed myocardium, typical of post-MI pericarditis. When we do the delay hyperannouncement, also you can appreciate that there's increased signal in the four-chamber view of the pericarditis. And it's very important in patients with heart failure just to differentiate patients with restrictive cardiomyopathy from constrictive pericarditis. This patient has a thickened pericardium, and you can appreciate the septal bounce of the septum. And there are other criteria that can be measured by cardiac MRI just to differentiate constrictive from restrictive pathology. This is another patient with suspected endocarditis. This is the 3D echo and this is the 2D echo. You would show a mass on the mitral valve. Very nice images from my colleagues in endocardiography unit. But actually this patient was treated as infective endocarditis, given antibiotics, but he didn't improve. We thought about other pathologies. We did a CMR, and as you see, there is a mass on the mitral valve, as the echo showed. But when we did the tissue characterization here, it helped us a lot. This is the tissue characterization. The mass showed enhanced T2 weighted images here on the left, and enhanced signals on the delayed enhancement, as we show on the arrow on the right. And this is not a feature of vegetation. This is a feature of non-infective endocarditis, or what we call Littman's sac endocarditis. So even here, the medical treatment was changed completely. Lastly, myocarditis, we have criteria for myocarditis and T2 weighted images. There's increased signal in early enhancement. After giving the gadolinium, also the signal will increase. And after waiting for 10 minutes, there will be delayed hyperenhancement, and you can appreciate here the lateral subepicardial fibrosis. Since we are in the COVID era now, this is an example of patient with COVID-19 infection, and he complains 4 weeks post-recovery of COVID-19, of sudden chest pain, ST elevation, elevated troponin, but a coronary angio was done, and he has normal coronary. And as you see here in the T2 weighted image in the left, you can see that there is increased signal in the myocardium, which is indicating presence of myocardial edema. On the right, you can see that there is a fibrosis in the inferior wall. Till now, maybe I have seen like 72 or 73 patients with post-COVID myocarditis. It's occurring a lot. Maybe nowadays it's less, but I mean, in the summer, there was a lot of patients with post-COVID myocarditis. So when you see a patient and ask him about the history of COVID-19, please just think about myocarditis. And as you see in the guidelines of the European CMR, the class 1 indication in myocarditis and pericarditis. Last thing is the new updates in cardiac MRI. We used what is called mapping technique, and you see that there's color images, and you can appreciate actually every single voxel of the myocardium that can be given a value just for early detection of many diseases, especially infiltrative heart disease. So even if the patient doesn't have a fibrosis or infiltration by the gadolinium, in these T1 mapping and T2 mapping and ECG mapping, it can give us additional information on every single point of the myocardium that can help in early diagnosis of heart failure. To conclude, the CMR is rapidly evolving as a versatile imaging modality that often provides additional information to echocardiography in patients with suspected or known heart failure. Actually, in many countries, CMR is still underutilized. Awareness of indication advantages of CMR in infiltrative and inflammatory cardiomyopathy should be increased among cardiologists. And please keep high suspicion of myocarditis in the era of COVID-19. Thank you so much. We have a happy anniversary. Thank you. I'm ready for any questions of the men.
Thank you very much, Professor. Professor Dr. Abara for this very informative, very comprehensive talk. But if we are in the emergency room and already have patient with heart failure, we diagnose him with laboratory and available echocardiographic techniques. How we put a protocol for the cardiologist inside the ER to send the patient for CMR. I mean, what are the indications or important indication for any patient to have heart failure, and we have to complete his study with CMR.
So cardiac MRI is usually not an emergency indication. There's no emergency. Probably myocarditis, this is one of the emergency indications that you need to just identify that this patient, or to confirm this patient has myocarditis. In some cases, patients with, if you need to assess the RV function in patients with pulmonary embolism or acute bronchial, this will also be helpful. Some of other indications of acute heart failure, patients with cardiac masses. Cardiac masses is very important to assess by cardiac MRI, since actually we don't do a lot of biopsies into myocardial biopsies nowadays. So CMR is the imaging modality of choice. If you have patients acutely ill and you need to know like big, large myxoma in the left atrium, and you don't know if this patient has a thrombus or myxoma or whatever, or something malignant. So CMR has little indication from ER, but there's a protocol for any patient with heart failure to do a CMR. In the CMR lab, we have a protocol that we look at the anatomy first, then assess the function of the left ventricle and also the right ventricle. So right ventricle is essential in assessment in every CMR study. And then we look at if we're suspecting inflammation, we do the T2 weighted images, and we do finally the delayed hypertension. Sometimes when we have time for suspecting ischemia, we can, and the patient has favorable conditions like his heart rate is between 60 and 65, and he has regular heart rhythm, we can look at the coronaries by cardiac MRI. And of course, CT is the imaging modality of choice for coronary angiography, but sometimes we have the time to look at the coronaries. Many times, actually, we discover just anomalous or proximal lesions in proximal RCA. For example, I have like 3 cases who was discovered that they have proximal RCA lesions, sometimes in proximal LED. That can be sent to know the reason of the etiology of heart failure. So it's actually it's very helpful in the management of heart failure.
Thank you very much, Dr. Abara. And probably we now came to the end of the session.
Can I have one more question to Rahara?
Okay, Professor.
To Rahara, thank you very much for the wonderful talk. Just one more question, because we've been seeing patients in the COVID era in children with pancreatitis, pericarditis, myocarditis, and even Kawasaki-like aneurysms of the condyles. Have you seen any of these patients in the COVID era?
No, actually, most of my cases for congenital disease are not like pancreatitis, mostly are adults. Some cases I have seen with rheumatic heart disease, pancreatitis. I have seen 2 cases since we have rheumatic heart disease, but they are not so many nowadays. But we don't see that referral from pediatric oncology. Mostly are, as you know, tetralogy of Fallot, as you sent me, tetralogy of Fallot and other congenital anomalies and follow-up for other congenital. But actually, CMR is very helpful in detection of inflammation. So, looking at myocarditis, we have seen a lot of patients with myocarditis. So, yes, I mean, regarding just myocarditis, not pericarditis, we can see by CMR. I have a lot of cases with myocarditis in children. And actually, by echocardiography, it's difficult to say that this patient has myocarditis. The main 2 things that we use is the T2-weighted images and delay hyperenhancement, and usually they have positive findings on CMR that can help us to know the etiology of heart failure in such children.
We've been seeing this in the COVID era. They're all COVID positive, and they're all PCR positive patients, and they come with pancreatitis. And I even have a patient with giant corneoaneurism like Kawasaki, and they do have something like MESI, which is multi-system inflammatory disease. And we've been seeing this a lot with children in COVID era. So you haven't come across them.
Yes, actually, we have seen children. I mean, we have seen like teenagers, 14-year-old. Last week, I've seen a patient, 15-year-old girl with post-COVID myocarditis. Her ejection fraction was 15%, which is awful, actually. So sometimes with myocarditis, we encounter what is called perimyocarditis. So I mean, we see in this area a lot of cases, but we don't see endocarditis like pancreatitis and Kawasaki.
Thank you.
Thank you. Thank you.
Thank you.
Okay, thank you, Dr. Rai, and thank you for our distinguished co-chairing this session.
Thank you very much, Professor Max, for your great contribution to this conference. Thank you.
Thank you, Dr. Magdi, for arranging it and for inviting me. Thank you very much.
May I ask Dr. Hamza and Dr. Muhammad Gamal and Dr. Magdi to stop the panel discussion, please. We are having Dr. Tariq Zawawi and Dr. Ahmed Fathi online.
Professor Ahmed Fathi. ازي حضرتك؟
Yeah, hello. ازي حضرتك؟ Professor Magda. First of all, I'd like to thank you for your great effort to prepare for this scientific activity, and I hope the next year will be together live in the same setting, inshallah. Yes, you hear me, Dr. Magdi?
Yeah, thank you very much, Professor Ahmed, for joining us today. Thank you very much. This is a new style for session, or new format for session. Not a lectures, but it's a panel discussion for difficult questions or issues which are raised in the clinical practice, and there's a controversy or a new opinion or new trials, new difficult scenarios in the clinical practice, and we try to put it in questions for the speakers and the discussion between the speaker and the moderators and the panelists. So I have the pleasure to co-chair this session with my dear friends, Professor Hamza Khabir, Professor Muhammad Gamal. We have Professor